Okay, it's time to start. We are here in my Aligners Intensive course. Thank you so much for your presence. And this is a course where we are discussing advanced biomechanics with aligners and also all the adjunct therapies that can help aligners to be more effective, to be more predictable, to provide faster movement. So everything that can help orthodontics with aligners to help plastic to move teeth better. Okay. My name is Daniel Ramos. I am from Brazil. I am orthodontist for more than 20 years. Right now, for the past 2 years, I am living here in Madrid, Spain, where I am coordinating the DST Planning Center Orthodontic Department. And also we have a treatment planning service only for aligners case that in the past 2-3 years we did more than 2,000 cases. And this is the basis, the foundation for the concepts we are sharing in this course. Okay, if you can find me, here you have my Instagram. This is a eight modules program. Okay, we have 8 webinars, 1 hour each, where each one we're going to go deep in some specific point, important point for us to create this protocol, this sequence of evaluations, procedures, and planning that we need to do to solve these complex cases. Okay. The webinar number 1, we review the most important concept for our diagnosis. And in my opinion, this is still the most important part to diagnose better how we can provide better solutions for complex cases. Understanding where we want to be in the end, it's going to guide us on how to get there. Okay, today it's going to be a special webinar because I'm going to share with you what we consider, and I'm talking we because I'm working here with a big number of dentists, orthodontists, everyone collaborating and providing great solutions for every case. And we are doing a lot of Invisalign cases, a lot of aligners cases, that we have some protocols that are working very well for these cases. And I'm going to share the most important ones, the ones that is going to open your eyes to solve these difficult cases. Okay, and then in the sequence of this course we have the part where I'm going to share all the strategies, the adjunct therapies that can help aligners to be better. Okay, so today it's all about biomechanics and planning. Okay, because nowadays with the softwares we are planning all the biomechanical strategies for the cases in the software before the treatment starts, right? Of course, later we can implement elastics, buttons, but the most important decisions we are making in advance. So it's very important to have clear protocols that can really help you in that sense. Okay, just reviewing the last webinar. If you didn't have the chance to watch it, I really encourage you to go there. It's going to make a lot of sense for a lot of decisions that we're going to see us making here in this course. But the first webinar, in this slide, we can summarize everything we talked there. Okay, that we are going to start our diagnosing process by understanding the upper ideal, in the upper arch, what is the ideal design, where teeth needs to be to respect the face, right? To be in accordance with the face, the lips, the midlines, aesthetics, right? And also the area, right? Because the upper arch, if it's more retracted, can reduce space for area. If it's more procline, we need to understand if we have margin to retract, we need to expand. So a lot of decisions are influenced by the area aspects. Okay, by understanding the ideal upper, we're going to adapt the lower, thinking on the functional part. So upper first, lower functional, to adjust the occlusion in the position the TMJs are in a better are in a balanced position. Okay, so the 3 rocks that can define the first step for us to simplify complex cases, the diagnosing part, are guided by the face, the area, and the function, here with the TMJ and occlusion. Okay, By having this clear, more and more, we're going to understand that sometimes this apparently complex case, after we start splitting and dividing and separating these aspects and gluing this sequence, we can understand much better what we need to do. Okay, so the goal now, after we provide a very correct, a very accurate diagnose and understand where we need to be, it's the moment that for orthodontics we need to understand how to perform, right? And how to perform well, with good decisions, with predictable outcomes. So this is our goal here when we start talking about the protocols. So it's very, very important for us to understand that inside the software, what we are seeing now is not anymore an static design, our target. But in the aligner software, we are dealing with biomechanics, we are dealing with a force system, so we need to understand this to get to be clear, right? That the final position we're seeing the Invisalign software, the Approver software, the SureSmile software, the software that you prefer for the company aligners you like to use, this final position is the shape of the last aligner, is where the last aligner is moving teeth. So we know the initial position, the number of aligners, what each aligner is going to do, and the last position, as they are claiming to be the final position, is just the shape of the plastic. It's like bending wires, right? So understanding this, it's going to be much easier for us to understand what we need to do. What are the rules, right? What are the most important aspects that we need to consider to be accurate when planning aligners case in a software. Okay, so this is what this webinar is about. When we are talking about softwares that we can plan, we have these steps that before we implement any strategy, which is the step number 6, the last one, we need to validate a lot of things before. Okay, so I call this the checklist, the 6 steps to make it right. So the first one, each company has this more than one product most of the times. Okay, a more comprehensive package with unlimited aligners, a more lighter package with a reduced number of aligners and refinements. So my opinion here, the step number 1 is very important to start with the most comprehensive one. I'm going to explain why in few slides. Okay, so here in step 1, if you want to make it right, allow the software to show you everything that can be done before you decide, before you make this decision to downgrade to a more a cheaper package or with less aligners if it is interesting for the case. Okay, the step number 2, I know for the main companies that you can personalize some aspects with your clinical preference. Okay, so if you have some strategies that you are using for a lot of cases that are working well, you can create your clinical preference for all your cases to use these strategies. For example, here's the moment for you to inform the company that you prefer inserting attachments only in the stage number 2. So you can have the stage number 1 without attachments, and it's going to be easier for the patient to adapt. Okay, this is just a quick tip, something that we discussed much more deeper in the previous course, the first aligners intensive, the one that we discussed a lot of protocols about aligners and more simple cases. Okay, and this is valid for these advanced cases too. Okay, so you have at this moment step number 2 to allow the company to know your clinical preference about this, when you want attachments, and a lot of minor other decisions here. Okay, step number 3, this is something surprisingly a lot of doctors don't realize to do, is to check if in the software the initial occlusion is according to what the patient has in his mouth. Okay, so we need to check the STL files that are the impressions and use some references, right, to guide and see if it's in the software is exactly like this, okay? This is the moment to provide also a good centric relationship, so you can plan considering that the TMJs are in a good position, okay? This is we discussed in the previous webinar, okay? Also, a lot of times in the step number 4, the company provides you some comments about the STL, about the files. Always review these because sometimes it's going to create some limitations for the case. It's important for you to understand if it is better to stop, take new photos, take new STLs, new scan, and then keep going, or if it's something that is not going to make a difference, okay? And the step number 4, the final position, okay? So before you implement any strategy, it's good to you to check if the final position, the final occlusion is good, is that what you are looking for, and then remember the concepts I mentioned, right? The photos they are going to help you understanding where the incisors needs to be, if you need to intrude, extrude, the anterior posterior, the expansion. All these decisions you need to make at this moment to understand from the initial position where you need to move to get to this final position. This is why I am reinforcing here. It's very important that you select a software that can allow you to integrate a photo with Smile, and you can see these inside the software, okay? A lot of companies, they are using this basic concept that ESD here is using for a long time, okay? And it's important for you to use a software that can allow you to evaluate this, okay? After doing all these checklists, this is the moment for the step number 6, right? To create the modifications inside the software, okay? I don't know if you ever heard, but considering aligners, most of the time, doctors, they are accepting the first plan that comes from the company, okay? You need to understand that most companies, the major one, Invisalign, for example, they are using technicians, not dentists, not orthodontists, to plan the cases. And it is a software with artificial intelligence that is helping by the database they have for other cases, right? But considering that most, and I'm talking about 67% of the cases, they are approving before make any modification, and this is completely wrong, because you need to understand that each case has its own needs, and you need to adapt to your patient the strategy. Okay, you need to adapt to the ideal final position that you are looking for. You need to adapt to the diagnosis you made. Okay, so you need to understand that the plastic has a lot of limitations. The same way any orthodontic appliance has some limitations. So by understanding the limitations that we are going to do today, we are going to create strategies to compensate and to simplify. Okay, so today I'm going to talk about comprehensive cases, right? That you probably need more than just 15 aligners and more than just one set of aligners, okay? And I'm going to present you my protocols, most important ones that you need to know to solve your complex case. The first thing that is important for us to understand, and this is something that the technology is helping us a lot, right? Because this article from 2016 is saying to us that we have a limit of force that we can apply that is going to promote a physiological movement, okay? That is going to activate this inflammatory cascade that is going to provide the bone to remodel and tooth to move, okay? We have a saturation point. So what we understand here is that we need to calibrate the best way possible the force to not overcome, to not surpass this saturation point. Otherwise, the inflammation we are going to create is not going to move teeth, but it's going actually to stop the movement, and then it's going to take more time, okay? Understanding this, it's important also to know that depending on the age, we're going to have a higher saturation point if it's a younger patient, for adolescents, and a lower saturation point for adults, okay? Most of the comprehensive cases that we are dealing, interdisciplinary, that not only orthodontics we're going to solve and need implants, restorations, surgeries, Most are in adults, of course, and then we need to calibrate the force for this group of patients. We also have complex cases for younger patients, right? And then we know that we can apply a little bit more force so we can efficient in our movements, right? And this is exactly what is, let's say, the secret sauce, the formula that the companies, they are not going to share with us. I already tried to ask them, I already tried to understand how they are calibrating the force for each kind of movement, right? But this is something that they are not providing this information because this is their technology, right? Intellectual property. So bringing back the what we already know for a long time, right, is that, for example, each kind of movement we need to apply different amount of force. So it will depend on the area of the root that we are moving against and compressing the ligament against the bone. So if we are intruding incisor, for example, the area that we are moving against the bone is only the apex, a small area, right? So we don't need to apply much force because it's less than 10 millimeters square. Okay, so normally for intrusions from 15 to 25 grams, it's something that we can activate this kind of force with a good amount of predictability. So how to make the plastic to do this? Okay, of course, the artificial intelligence for the major companies, they know this. They are improving this system and they are creating points of pressure and they are deforming the plastic in a way that we can activate in this amount of force more or less, of course, right? But what we cannot do in this moment is to ask the company, for example, to reduce the number of aligners. A lot of doctors, they do this in order to increase the, so we reduce the force for, or increase the number of aligners or reduce the number of aligners, to change the number of aligners, because each aligner is calibrated to provide more or less this force, okay? So if we are moving body mesial distal, we need to apply more force because we have a bigger area. So understanding these concepts, we are going to respect more this part of the artificial intelligence that can help us. It's very difficult for us to calibrate a movement that is complex, it's not just one kind of movement, to the amount of force that we need only by our free hands and using manual tools, right? The software can help us a lot, and this is something that is my rule number one. I'm using the software and respecting the number of aligners, okay? And this is why I prefer selecting a more comprehensive package, right? The one that is unlimited, that I can have as many aligners as I want. First, because before I approve the plan, the aligners, or notch the aligners, I can always change, okay? I can always downgrade and upgrade, so I prefer starting with the best possible, the one that can allow me to do everything with the artificial intelligence is telling me. Why this? Because imagine that the software can calibrate exactly the force you need to allow the tooth to move as you want, okay? But the patient is asking you for a cheaper package, you want to pay less, and you want to also to pay less, and you order there a light package with 15 aligners. The software will find a way to move teeth to the final position, but probably will activate with more force than you need, or it's not going to be enough, so it's not going to create the ideal amount of force. Okay. If you start planning by this, sometimes you miss the opportunity to understand that this case requires more aligners. Okay. So it's much better for you to start with a package that can allow you to have as many aligners as you need. And then, if to achieve the final position you want, the software is saying that you need only 15 aligners, then you can make the decision to downgrade. But you can also see that, no, for this case you need 30, so it's not compatible with the other. The only way to see this is by ordering the most comprehensive package. So always start your aligner journey, if you are starting, with a comprehensive, okay, with an unlimited pack. And with time and your experience, you know which product to choose, okay? But my preference still today is the comprehensive, because I have more time. I understand that refinements are part of the process. Sometimes I need to stop in the middle because the patient is not collaborative. I can order more aligners. It gives more freedom to work, right? And the most important part, the comprehensive pack allows the software to present the most clear complexity of the necessary complexity of the movements. Okay, so also it's very important for us to understand that even though the software is very good to calibrate the force, it's still not 100% accurate. Okay, it would be amazing. Imagine that if we plan the software movement to this position from A to B, and then the software calculates the ideal force, points of pressure, and then the final position that you plan actually happen 100% in patient's mouth. Okay, this is not a reality. Okay, and a lot of studies are showing this. This is one of the most important ones, but you are going to find a lot of others showing that the mean accuracy of all tooth movements with aligners is 50%. It doesn't mean that aligners, they don't work, okay? Because it worked very well. I'm working for a long time, for the past, since 2016, exclusive practically with aligners, and for more than 15 years, I'm using aligners in my routine, okay? So it's very important to understand that it works. But it's also important to understand these limitations, okay? Because if in this study they found that the predictability for intrusion movements is 35%, for rotation 46%, buccal lingual crown tip 56%. So the most challenging movements here, like an intrusion, if I accept the final position that it is in the software, right? Imagine that the final position that we are intruding is exactly what I want to finish. If the predictability is only 35%, it means that I'm going to achieve only 35% of what I plan, and I'm going to stay very behind the ideal final position. How to solve this? This is something that we need to understand, that is not, although we're talking about numbers, is not mathematics, okay? But this study presented to us minimum and maximum predictability for each kind of movement. So if we can see, we are not seeing many cases that we have more than 50%. Maybe in the second premolar here responded well for some movements, but the mean accuracy was 50%, okay? So how can we solve this, right? How can we be better? The word that you need to put in your routine for aligners is overcorrection. This is something that the companies themselves, they are trying to solve by some internal strategies, like creating bigger force, more flexible plastics, creating better solutions, and more, I believe the studies, they're going to show improvement in terms of the predictability, but we still need to overcorrect movements. So the same case that is the intrusion, I need to intrude more, knowing that the teeth is going to stay behind. So this way we can estimate that by intruding more, it's going to more or less be in the position we want. And this is why it's so important to also use a product that provides you more aligners, okay? And this is not new for aligners. This is not something that is new for aligners. This is something that we always did in orthodontics. For this case, a case like this, it's not the same patient, just using an example, that we have a reverse curve of SPE, right, that we need to correct and to plan to flatten this arch. What we do with the arch wire, right? We create this compensation, this overcorrection. So when we are going to insert in the brackets, right, it's going to be like this. I don't expect to move incisors to this position here that we are seeing the wire, but I want the wire to have enough force to promote the movement. How can we bend plastic? By doing the exact same overcorrection in the software, okay? So how can we overcorrect movements? This is my protocol, okay? And let's see an example. But it's very important first to understand where is the ideal final position. This is why before we implement the strategies, you need to first move teeth inside the software to the ideal final position, considering your diagnosis and everything you checked in the documentation. Okay, clear? Hope so. If you don't understand this, please make the questions in the end of the webinar. I'm going to answer, and if you're going to watch the recording later, please contact the OIGS team so they can forward the question for me, and I'm going to happily answer as I always did for all questions, okay? So here in the software, first define the ideal final position, okay? Then after that, you have some tools that can help you to understand how much movement you have from initial to the ideal final position. And by understanding this, we are using the 50% rule, right? This is the mean accuracy that we saw in the article. So if it is intrusion, sometimes a little bit more, but in average, we are overcorrecting 50%, okay? Let's take a look here, okay? Let me pause and move. This case, we are intruding here. You can see initial and final ideal position, okay? This is how much we are intruding, okay? Then I'm going to the table where it's going to show me the movements. So I know that from the initial position to the final ideal position, this lower right incisor is intruding 0.5, the 4.1, 0.6, the 3.1, 0.7, 0.9, 3.2, 1.1. So we have different amounts of movements here for this group of teeth, okay? So this is the important information that I need to collect in the software. Here is the CleanCheck, but probably any software and the main company software, they allow you to know this, okay? This information is very important. In fact, I always work my CleanChecks by having this table open so I can understand what is happening, okay? And then I'm going to evaluate this and I'm going to order a modification, okay? And then I'm going to individualize the amount of overcorrection I'm going to do by clicking in the teeth I want to intrude. So I'm going to 0.5 usually. Since this group is very close, I like sometimes to intrude equally, right? And I'm going to overcorrect the intrusion 1, 2, 3, 0.5. I'm overcorrecting to 0.8, which is a little bit more than 50%, okay? And then I'm going to select these incisors that are very close, and I'm going also to overcorrect about 0.5, which is what I need to do. And I'm going to calibrate also the cuspid that is intruded a little bit more because it needs to be intruded, it's kind of canted, okay? So this is how we are doing for a majority of the cases, these overcorrection, okay? If you don't have this table in your software, probably you're going to have a grid where you can see a millimetric grid so you know the distances, right? And there you can also calculate from initial to ideal final and how much you need to intrude, okay? Sometimes doctors, they are doing just visually, intruding a little bit more. It's going to work also, right? But it's much more accurate if you create some protocols so you can calibrate for your other cases, right? You can understand that maybe intruding only overcorrecting 20% is not going to be enough, and then you do a little bit more. You only can do this by knowing exactly what you are doing for each case. So understanding the diagnosis where you need to be, understanding that the software provides important information about the force that you should use it, understanding that you need to overcorrect, right, to achieve and compensate this lack of predictability that aligners have. The rule number 3, right, that I like to focus, right, in the biomechanics and the attachments and everything you need to implement to improve the retention of the plastic, okay? You need to evaluate individually each unit, each tooth, and focus on the most challenging biomechanics. And this is something that is not related to the amount of movement, because sometimes we have, for example, one tooth that is intruding 0.5, but tipping the crown distal 0.6. So the software may detect that the biggest movement is that one to tip the crown distal because it's 0.6 and the other is 0.5. But this is a predictable movement. This is something that is easy to the aligners to do. The challenge one is for intrusion. So we need to concentrate the strategy of overcorrection, attachments, and everything else for the most challenging movements, okay? And to understand a little bit more about what is predictable, what is intermediate, moderate, and what is difficult, it's something that takes a lot of time, experience, and you can also use some shortcuts. I like to read my peers' experience in this study. I found this is a study from 2017 from a team from Australia, and I really like it because I start seeing these numbers and okay, this is pretty much what is happening to me, okay? So I encourage you, if you want, to take a print screen of this slide, okay, and use this information so you can talking to the patient and understanding what we're going to discuss in this course, when to use, for example, skeletal anchorage, when to use an SFOT technique. These kind of numbers help a lot. So we are talking about predictability with aligners alone, only plastic, okay? If we have a crowning, okay, or a spacing, diastemas, up to 6 millimeters, something that it's easy to fix only with plastic. So here, just by implementing all the strategies we discussed, and we're going to review the most important ones for complex cases in this webinar, but the previous course, we are going to see much more details, okay? You can look for the OIGS platform, my name, you're going to see the other course I have, 12 modules with a lot of information about this kind of protocol, but here you see the predictable movements for each kind of type of movement, okay? We were talking about intrusion. Let's keep using as a reference. When we need to intrude the posterior, or let's stay the anterior is the example we use. In anterior intrusion, up to 0.5 is predictable. Okay, more than 0.5 and up to 1, moderate, and more than 1 is difficult. Okay, so this means that the difficult ones, we need to create an extra effort for the plastic to work better. Okay. And this is interesting information that I'm going to get back. Also, we know that there are some malocclusions that are more challenging than others. Some malocclusions is going to make us to use more our brain to achieve better outcomes, right? And we need to understand that inside each malocclusion we have several types of movements and necessities, okay? I can have a patient that is class 1 with a more complex malocclusion than a class 2, right? Or even a class 3, but we need to understand the cause. If it's dental, skeletal, growing patient, adult patient, lack of space, too much space, the problem is vertical, is transverse. In the class 1 we don't have the sagittal, but then if we have, it can be a class 2, a class 3, right? So we need to understand everything it needs to be done. That again, the diagnosis is the best way to start with the strategies I mentioned in the webinar number 1. Okay, so important notes, the complex cases, we have multiple types of movement. And it's important to understand the protocols for each kind of movement, for intrusions, rotations. How can we better provide a strategy that can make this movement to happen, okay? Also, the rule for attachments, every time you need to select an attachment that is designed for the most difficult movement. With Invisalign, we have now the optimized attachments. No, we have for some time, but the optimized attachments, they are targeting the bigger movement, right? And sometimes the bigger movement is not the most challenging one. So how can we know that? You need to put your mouse over the attachment. You need to check what's the reason this attachment is there. And if it's not the most challenging movements, you need to change. Again, in this course is not to discuss this. If you want to review attachments, the types, and how to position, go back to the course number 1, okay? Focus first, the first set of aligners in the most challenging one. I like to use the analogy for golf, right? The sport golf. If we want to do holy ones in our holes, it's going to be impossible. Even target woods cannot do this, right? So what we need to do is for our first shot, is to be very consistent, right? To put the ball the closest possible to the hole, so the rest it's going to be easier, okay? So we need to understand the biggest challenge here and focus the first set to turn the complex case in a simple case, and then the second set is going to be easier, in my opinion. Okay, I'm talking about complex cases, right? So if you try to do everything in the first set, sometimes we lose predictability, we lose tracking, and then we need bigger sets of additional aligners, and it's going to take much more time. Okay, and finally, we need to understand the protocols. If we have multiple movements for each kind of complex case, we need to understand the protocols for each type of movement. Okay, and then personalize the clean check or the software, the one that you prefer, according to each kind of movement. And again, prioritizing the one that is more complex, right? Because each tooth can have more than one type of movement. Okay, so I'm going to now provide you very direct to the points slides with tips. Okay, so we can understand for each kind of malocclusion or movement the strategies that you need to know. Okay, and this is made in a way that later, if you want to use the recordings, if you want to buy the recordings, you can go back and see for each kind of case how can you put in practice the decision making, and also how to use this inside the software. Okay, I'm going to use the software CleanCheck but for all the case, but you can use the same strategy for any kind of aligner software. So when you have a diastema, more space than you have than you need. Okay, the most important part for this kind in the diagnostic part is to understand if it is an ortho problem. In other words, you have a bad teeth position, but you have a good teeth proportion. Okay, you have all teeth in a bad position, but moving them to a good position, you're going to close the diastema. Okay, if this is the situation, only with orthodontics is enough, and you are going to achieve a stable outcome in the end. Okay, if you have bad teeth position and also bad teeth proportion, this is something that not only ortho and not only restorative, because it's not in a good position for you to close the diastemas with restorations, right? And also, if you move only with ortho, because the teeth doesn't have a good proportion, you're going to also have a lot of space there. Okay, so this is the kind of case that you need to move teeth to its position and then close these diastemas, achieving a better proportion with restorations. Okay, if you try to close space with ortho, you probably are it's not going to be stable, and this diastema is going to come back in a relapse. And finally, a lot of cases you have a good teeth position but a bad teeth proportion. The same way, you cannot try to solve this with movement, okay, because it is in a good position, okay, and you need to fill these gaps, recovering the anatomy or the ideal proportion this teeth needs to have. Okay, so this is my template to decision-making process. When I'm working with diastemas that we have a lot of space, imagine that you need to close a 1 millimeter diastema. Okay, this is something that it's predictable for aligners to this bodily movement mesial distal. Okay, if we have more space than that, it starts to be less predictable, but 1 millimeter it's good. But again, how can we overcorrect this if it is not something that we have 100%? We saw in the study, if you go back to the slide there, later in the recordings, you are going to see there is 56% in predictability, the specific study, but a lot of others corroborate with this. How can we overcorrect? Because if I close, I'm going to create contact. I cannot go more, right? The way I can do this is by adding what I call fake IPRs. So I add in the software, I'm going to do an interproximal reduction. So the software is going to consider that I'm going to do this and is going to overlap in the software one teeth with the other. This way I can make the plex to have an extra force to create this movement. Okay, so this is a simple tip, okay, that can be done for mostly all your cases that teeth are in a good position, you need to move and you want to overcorrect this to avoid leaving this residual diastema there. So this is something you can order if you cannot do by yourself in the software you are using. You can say to the technician from the company that you work, please add an IPR between the centrals. between 1.1 and 2.1. 0.2 for less than 1 millimeter space, diastemas, and a little bit more, 0.3, when you have a bigger diastema, okay? This way they are going to insert, but you need to remember, you need to take note, because this IPR you are not going to do later in patient's mouth, okay? Maybe this is kind of tricky, and if you don't understand, please ask me later. I'm going to get back here, okay? Also, for all body movements that we need to do, we need attachments, and ideally we need rectangular attachments, okay? Optimize, can be vertical. I have it here vertical, but in fact, even horizontal is going to work. What we need is to create a rectangular attachment so we can have this binary force in two surfaces to create resistance against the movement, okay? And again, also, another way to do overcorrection is adding resistant to root tip, right? So if the tendency, for example, to close a diastema between the centers is that the crown is going to inclinate to mesial, if we create this resistant torque to root tip to mesial, it's kind of creating this compensatory and overcorrecting this movement too, okay? So the diastema probably is the most simple way to solve in our cases, okay? A little bit more tricky is the crowning, okay? Sometimes it's easy, like this example here, simple crowning that usually only with expansion, proclining, improving arch width and perimeter, we're going to open enough space to solve, okay? So this is the kind of case that we don't need here to discuss strategies, because it's very simple, and even accepting what is coming from the technician from your company is going to work fine, okay? Sometimes we have a bigger crowning that we need to consider IPRs and also mesializing, distalizing. So we need to change the mesial distal with mesial distal movements. So this is something that here we need some strategy that we're going to talk when talking about class 2 corrections, sequential movements, okay? IPRs also, most of the times we need to add, and very, very big crownings, complex crownings, sometimes we need to try the first ones, and if not possible, consider extraction, okay? And here, this is the beauty of using softwares that we can test drive and avoiding doing unnecessary extractions, because in the software we can simulate expansion, distalization, IPRs, and try to put our teeth inside the bone, right, and correcting the crowning, okay? And we can check first, and then if it's not possible, leave extraction as the last resource, okay? By expansion, we need to understand if we have the crowns retroinclined, it's easy, like the example here, right? The crowns are in blue original position, the axis of the tooth, and we need to expand, but proclining the crown to buccal, okay? This is one of the most predictable movements that we have, but we're talking about complex cases. Sometimes we need to expand in a body movement, right? The initial position already has the crown not retroinclined, and we need to expand because we want to open space, okay? So for this kind of case, the first one, we don't even need to bone attachments. It's going to work fine, okay? We can do all add-ons, all the movements add-ons, okay? When we need to do body movements, I like to add the second molars as anchorage. So while we're expanding from the first molar to cuspid. So I leave the expansion of the second molar for a second moment after finishing the expansion of this group here. And it's important, very important, to insert a rectangular attachment horizontal in the for root control, like this, okay? Because if we don't want to procline, the other example, when we have the crown retroinclines, we want to procline, so we don't need to offer any resistance here, okay? But by having the need to do body movement, we don't want the crown to procline, so we are adding this so we can create this point of pressure here to compensate and try to bring tooth in body movement with more efficiency, okay? So for expansion, if we can use for some stages the second molar as anchorage without moving, you ask, or this is something you need to ask. Stage you need to write and ask the technician. So you're going to write there, start expansion with teeth 1.6, 1.4, 1.5, 1.4, 1.3, 2.3, 2.4, 2.5, 2.6. And when they achieve 50% or 70% of their movements, both were fine, you can start expansion in second molar, okay? And this is something that is going to improve. Plus adding this kind of attachment, rectangular with the bevel facing the gingival margins, and creating this resistant binary force to compensate the inclination tendency we have. We need to evaluate, of course, how much we need to expand. This is a good reference for us, the distance, the intermolar distance, right? And also the interpremolar, but the intermolar, we should have at least 34 millimeters, ideally, so we can have good space for the tongue and for airway, okay? We also have the volar ridge, which is the most external area of the alveolar bone here in the buccal side. We can see this in a occlusal view of the model, okay? So we know that we may have bone there to procline, okay? We need to check ideally a CBCT, check perio conditions if we have recessions, and to understand if this is the kind of case we need adjunct therapy or not, okay? Also the IPRs, that some cases for crowning, most of cases for crowning we need, okay? My tips here, it may look basics IPR, right? But I also like to share these tips because a lot of doctors ask me, okay? But I don't like to do more than 2 millimeters in one appointment. So I usually do maximum 2 millimeters for the appointment, and then if necessary, I do the rest in the second appointment, okay? You always use straight stripes, right? Because we don't want to compromise the crown anatomy, this curve between the reflective and the deflective area of the crown. Who works with restoration understand this, okay? But this area is very difficult later to reproduce with any kind of restorations, and if we mess with these, we may mess also with the visual illusion of the proportion of the teeth, okay? I'm going to explain this in the next slide, but and when we have 0.5 or more, always prioritize removing from the distal side of the tooth, okay? If you have a cuspid, the 1.3 and 1.4, do the biggest part of the distal of the 1.3, because this is something that in a frontal view we cannot see and cannot compare with the other side, okay? Like this. This is very important for anterior teeth mostly, okay? In this frontal view, who is seeing, or even the patient in the mirror, is going to see these white areas here, okay? The other is going to be shadows. And if we need to remove a big amount of enamel, like 0.5 in my opinion, ideally in the distal, because we're going to remove from the shadows, right? And also here you can see a scheme that, illustration, sorry, that can show you the reflective area in this lighter gray and the deflective area in this curve. The curve that connects this area with this lateral area, it's very difficult to reproduce, and nature does best, okay? By using this straight stripe, we're going to only remove here without touching in this line, okay? And if we touch this line, we're going to wear it, we're going to reduce and move it in more inside. So this reflective area is going to be reduced, and then we're going to have a different perspective of the proportion of the incisors, okay? Let me know, this is a topic that I have a course specific to talk about this kind of thing, and it's not in this course yet, and not in the previous course yet, but I'll be glad to answer anyway, okay? And then extraction in cases with aligners. It's possible, it's recommendable. In here, it's not aligners, it's any kind of orthodontic appliance, right? I don't like to do extraction. I want to avoid as much as I can. So I want to eliminate all other, and I want to simulate before deciding for extraction. Okay, so I perform extraction if I need to. Ideally, another tip, right before ortho, so we can use the inflammatory response in our favor. Okay, and I'm going to explain this with images. We need to compensate this because the force of the plastic when we are closing an extraction site, it's going to deformate the plastic, and we have the tendency not only for aligners but also for braces to do this bowing effect. And this is a case that happened, that it wasn't controlled. We opened the bite in the posteriors, okay? So what we need to do to compensate in the software, overcorrection. We need to intrude the incisors and the molars and do a tip back band, but in the plastic, to tip the crown back, and here to tip forward. So we can create the shape of the plastic like it would be the shape of the arch wire, so we can have compensation to avoid the intrusion of this segment. Okay, so this is something that create a reverse arch curve in the plastic. So how we can do this in the final position of the software. Intrude and tip back molars, intrude incisors, and increase crown buccal inclination. This way you are going to prevent this. Okay, now let's start talking about more complex malocclusion. Okay, we have open bite, and here again the diagnosis is the most important part. But how can we solve the open bite, anterior open bite mostly, the complex ones, is by intruding posteriors. Okay, and when we intrude posteriors, we're going to promote a counterclockwise rotation of the lower jaw. We can extrude anteriors, we can combine both, and also it's important to consider extracting third molars if they are in patient's mouth. Okay, by defining our goals, the intrusion for posteriors here, posterior intrusion per arch, we have that more than 1 millimeter is difficult. Okay, so you need to check that in the software and overcorrect. Okay, but my rule here is that when I need to intrude up to 0.5, this is something only with plastic. If it's up to 1 millimeter, I tend to overcorrect more and do sequential movements, okay, of the intrusion, as I'm saying here. And more than 1 millimeter, I like to encourage patients to use skeletal anchorage so we can be more efficient. And this is going to be our next webinar, okay? So here, remember this when we are going to plan your next case. These open bite protocols, when we need to extrude, we need to add retentive attachments, otherwise the plastic is not going to hold the crown, it's not going to be efficient, okay? You need to consider for more than 1 millimeters using skeletal anchorage, overcorrection of 50%, and also I like to use as much help as I can, so these fake attachments in molars, that is these attachments in the occlusal surface, is going to work as a tabletop and improve the force system for the intrusion in the posteriors, okay? And as for you to know, a case here that we did a quality control recently, after 6 months using skeletal anchorage in this biomechanics, that you insert and last from one to the other, passing over the aligners, we could intrude 2 millimeters, okay, in the whole posterior quadrant, but in this area 2 millimeters in 6 months, and it's the double what the study considered difficult only with plastic. And here, of course, it only can be achieved because we did with skeletal anchorage, okay? Deep bite, it's the opposite. We still dealing with different movements, the same kind of movements, but in different order, right? Intruding and extruding, okay? For deep bites, of course, we need to intrude the anteriors. We need maybe to extrude posteriors and open the bite at vertical dimension. A combination of both. The diagnose, again, the most important part, okay? And sometimes if we have wear, we can open the vertical dimension and put tabletops in the posterior, so we can establish a better vertical dimension here, and it's going to facilitate the correction. When we are talking about intrusion, we are seeing a pattern here, right? We are talking about, again, overcorrection and at least 50%. I also like to overcorrect posterior extrusion. So the software, we are going to see very heavy occlusal context. And when we are talking about extrusion, we need to add retentive attachments. Otherwise, the plastic is not going to hold the crown and promote the movement. Okay, and every time you can add bite ramps, it's very helpful for anterior intrusion. This is a tool that I really like. We are using for a lot of cases. The only situation we cannot use is when we have the crown retro-inclined and we don't want to start the intrusion with the roots facing towards the buccal-cortical plate. So this is the PIR strategy. Procline first, then intrude, and then, if necessary, retract. Okay, so this is a summary of how you need to see the software and plan a software for this kind of malocclusion to make it more predictable, to make it easier to correct. You're going to overcorrect the extrusion in the posteriors, leaving heavy occlusal contacts. It's not a problem. It's not going to happen, I promise you. You are going to over-extrude this sector. You are going to over-intrude this and also intrude the second molar, so you can create this reverse curve. And you're going to overcorrect intrusion in 50%, if possible, with bite ramps. Okay. Here is why I don't like to use the bite ramps in cases like this, because the crown is very retro-inclined, the roots is facing the buccal-cortical plate, and then this is something that we don't want to intrude at this moment. Okay. Here, just for you to understand, creating the force system and attachment selection. Let me pause here. This is the case how it comes to me. Okay. I'm checking the CBCT. This is something that I'm using more and more. Okay. And then I'm going to explain why we cannot intrude since the beginning when the crowns are retro-inclined. Okay. So I'm doing here the overcorrection, right? This case, what I'm doing, what I explained, right? This is the final position, and in this transparency, the initial position. So I am over-extruding the premolars and the first molars. I am over-intruding the anteriors, over-intruding, tipping back the molars, over-extruding the first molar and the premolars. So the arch shape is going to be like this, okay? And very important, adding these rectangular attachments with the bevel facing the gingival margins, so you know that it's going to be very retentive and is going to provide the best anchorage system to correct this deep bite. Okay. This is a case we perform just for you to have one case with the after the result, right? This is how much we need to intrude, comparing ideal final position and initial. In the clean check, we are creating the same strategy, the same kind of attachments, extruding premolars, overcorrect intrusion in the anteriors. We are trying to reproduce what we always did with braces here. This is the difference between initial and final, okay? We have in this, the incisor that is more extruded, 4.95 millimeters, okay? And just for you to have an idea, the orange is the initial, the green is the final ortho, the yellow is the design with the restoration this case is going to receive, and in the sand color, this is actually the final position after doing ortho, okay? And we do this by creating these strategies overcorrecting to achieve this amount of intrusion in one side of aligners, okay? Moving to class 2, because a lot of tips and not money time. Class 2, we have two important decisions here, important evaluations. It's a dental class 2, it's a skeletal class 2. So for skeletal class 2, sometimes the complex turns simple, because the way we can solve is by doing orthognathic surgery for adult patients, or by using the growing factor in our favor with some mandibular advancement, okay? The most challenging class 2 is the one that it's already dental, we have a skeletal component that we cannot use orthognathics, we cannot use this anymore because the patient is an adult, okay? So we need to consider retracting the upper, we need to consider adding IPRs, sometimes extraction is the only way, and skeletal anchorage or surgical facilitate, okay? And here the table for us to remember. If we need to move distal to correct a class 2, up to 2 millimeters is something that the software consider predictable, okay? By adding sequential movements, this is something can be done only with aligners. more than 2, it's kind of mandatory to include elastics and consider also sometimes skeletal anchorage. More than 4, it's a very difficult case that you require more sets of aligners, all the strategies before, and probably skeletal anchorage is going to be mandatory. Okay, but for growing patients before, this is something that we need to understand, because if we're going to do the mandibular advancement, it's where we can use with aligners nowadays, right? Otherwise, we're going to use a class 2 elastic to retract the upper. It's very important to first correct in a first phase the vertical, okay? Because most of the time, the class 2 patients that we want to do mandibular advancement, they have a vertical component that is blocking the mandible to grow, okay? So the first phase before we promote the advancement is to intrude the anteriors, and then we're going to promote this movement here, right? We are intruding, and then just after that, opening space, we're going to advance and stimulating this more anterior position of the lower jaw, okay? So a lot of times I see doctors complaining that this mandibular advancement, these wings doesn't work. They don't work, but it's because they didn't change and correct the vertical first. Okay, so we need to open space so we have space for the mandible to advance. But the most challenging class 2 are the ones that are adult patients that we need to retract the upper arch, and this take time. Okay, so here are my insights, right? We have they are indicated for dental class 2, so the patient has the upper arch proclined. Okay, they have a great predictability up to 4 millimeters. More than this, we need to consider skeletal anchorage and other strategies. Okay, and the sequential movement, I like to use the 50%, which is like this. Okay, if you want to take a print on that, be my guest is how I explain to the company how to do. So I need to write there when I'm submitting the case, do sequential distalization on teeth, and you need to number the teeth you want to do this. Okay, of course, this is only one side. If it's both sides, you need to specify that. You start by the second molar, of course. Then start the movement of the first molar when the second achieves 50%. Use this pattern for the subsequent movements. This way, we are going to create like this, okay? You can see that we are not retracting all at the same time, okay? We are first moving the second molar, and then the first molar, and then the premolar, and then the other premolar, and then the anteriors, okay? This way, this sequence movement, what's the idea here? We always will have at least 2, 3 or more crowns being used as anchorage while we are moving 1 or 2. Okay, these lines are not overlapping one the other until we finish at least the first movement to start the other. So here, when we finish the second molar, we are now moving the premolar. So this is the whole idea, to create an anchorage system and to improve the predictability and to avoid losing tracking. Because if we want to retract all posterior at the same time, when we're going to retract the anteriors, probably we will lose predictability and it's not going to work, okay? And elastics, right? Elastics, part of a class 2 correction. We need to consider adding buttons or these cuts that we can use to fix the elastics, and this is something that can help a lot. You saw in the previous case that we had elastic here from a button to this cut, so we can promote this retraction help and to help correcting this class 2. Okay, I like to use the 316 light force light to medium, this one that I'm specifying here, full time. The patient is going to change elastic every day and is going to use full time all the time when they are using the aligners. And finally, for class 3, again, the same diagnostic moment, right? It is dental, it's skeletal. Sometimes it's just a deviation of the lower jaw because the occlusion, we can compensate with movements that correct. But most of the time, the class 3 appears as with a skeletal component, okay? And most of the time when the skeletal component is not correctly compensated with the maxillary advancement when the patient is young, this is the kind of case that for us to fully correct it will require orthognathic surgery. Okay, so class 3 and extraction is something that it's not a match. Okay, avoid, don't do it, because the last thing we want is to compensate the lower jaw, which is more advanced, extracting more premolars, for example, retracting for many reasons. Okay, we can consider some distalization of the lower posteriors. We can consider selective IPRs and even skeletal anchorage to help in this movement. And the SFOT technique, which is a technique we're going to discuss more and more in this course, can help us to create some bone there to move teeth and to compensate this skeletal class 3. Okay, but again, here, remember this table. If we need to distalize anteriors, right, and the lower arch, we need to consider that there is some limitations for the plastic. There are some limitations from the bone, because everything we distalize here in the posteriors, even if you have this third molar space to do this movement, 4 millimeters, great, but we won't have this amount of movement to retract here in the anteriors, to retract the incisors, right? It's a very limited amount of bone here that we need to check and to see if we have space to move, and if it's worth it to do this retraction, because there are going to be some considerations in terms of airway, space for the tongue that we need to check. But the same strategy here, if we want to distalize the lower posteriors, the same way we can do, and I explained for the lower, the upper posteriors, okay? By doing sequentially, you need to number the teeth you want. You start by the second molars, then move the first molars when the second achieve 50%, and repeat this for the others, okay? This way, you are going to have more predictability. Class 3, again, super important, okay? This is something you need to use so you can have a great, better predictability and avoid losing tracking and anchorage the anteriors, because sometimes when you are distalizing posterior, you may have a proclination component in the anteriors and make the class 3 worse. This is not good for the patient, so using the elastic can prevent this, okay? So again, the 316 elastic, light to medium, full time, changing elastic every day. And finally, what is going to come with the next webinars, but a spoiler at this moment, the rule number 5, after all these tips for each kind of movement, right, is, or the most important ones, we need to understand the limits of the plastic. And by understanding the limits of the plastic, we need to understand when is the moment to add additional therapies. Sometimes it's just a restoration, because the plastic cannot increase, the size cannot change the color, right? The orthodontist cannot do this. Sometimes it's because we achieve the limit what aligners can do, and then we need help to improve the anchorage system. We need help to promote a better bone modeling. And this is something, this graphic here showing the limitations of ortho alone, ortho plus orthopedics in this yellow, and the old one, the surgery, in this purple. We now have, with skeletal anchorage, more range to work with ortho, right? So only ortho come from this point to this point here, sometimes only by adding skeletal anchorage with TADs, okay? And by understanding when it's difficult to move, it's easier for us to understand when it's a moment to insert this tool, which is very simple, okay? We need to go back to this slide, understand that we have some limits in terms of force. And even using the best technology, we cannot be more efficient by applying more force. So by understanding the limits of the biomechanical stimulus, we need to understand how to improve here the better biological response. So, and this is the moment that we can overcome the limitations that orthodontics, even with skeletal anchorage, it has, right? And these are the techniques that I want to comment with you also in this course, that they can promote a better bone remodeling, okay? This is something that we're going to discuss in the next webinars, right? The use of the high frequency vibration, the use of micro-osteoperforations, and the use of corticotomies, okay? We are going to talk about orthognatics and the combination of ortho and restoration. So I'm trying to fill in all the gaps so you can have at least a preliminary and important package of information for you to go further these solutions for your cases, okay? Then this is the next webinars. We already did these two ones, okay? We have the from 3 to 8, now just to discuss these adjunct therapies. I hope you enjoy this webinar. I know it's a lot of content. Please make the questions you need so I can clarify the points. Here you also have my Instagram in case you want to send me a message, but if you want, you can just contact the OIGS team. They are super helpful. They are going to guide you. They're going to forward the message to me. In fact, I'm looking to my iPhone right now, waiting for a question. And if you want to do at this moment, I will be happy to answer. So, no questions for now. I'm going to be here, okay? Today I promised a webinar of 1 hour. You receive extra content, right? It was a little bit more. I talked too much, so I would like here now to hear from you. So if you want now at this moment, but I know a lot of doctors, a lot of colleagues prefer watching later the recordings, or going to watch later in another moment. And if you want to review later and then make the questions after, no problem at all, okay? Let's wait a little bit more, not a big deal. Let me ask here, Valeria, my dear friend from OIGS, she's always here with me helping, and all the team. Thank you so much for your support. Let me know if there is any other question appearing, if some doctor is typing, hopefully, or they understand everything, or I don't know, no questions. Well, I'm up to you guys. Let me know if you want to consider this webinar finished. I'm up to you. Otherwise, I can wait a little bit more. Okay, and please don't forget to go there, follow me Instagram. Let's keep in touch. I'm trying to share a lot of content. I'm trying to be available to answer questions. So it's very important is to use these digital platforms to grow together, okay? No questions? No? So, team, can we finish? Let me know. Okay, people are shy today. Let me know later if you have any questions, but for today, again, thank you so much for your participation. Thank you so much for being here. Everyone who attended and who is going to watch later, thank you for the team in OIGS, and see you in 2 weeks in the next webinar, the number 3, where we're going to discuss about biomechanics with skeletal anchorage, okay? See you there. Bye-bye.